Welcome to This Explainer. Today, we're literally stepping into the shoes of a diagnostic detective to solve a really high-stakes clinical mystery. We're going to explore the fascinating, complex, and honestly, sometimes incredibly urgent world of orbital diseases. You know, when a patient presents with an eye issue, the clues are usually all right there, just hiding in plain sight. It's our job to read them. So, picture this scenario. A patient walks into your clinic, and the very first thing you notice, their primary symptom, is proptosis, a bulging eye. As a clinician, your mind immediately goes into overdrive, right? Is it an infection? Maybe some kind of autoimmune issue? A slow-growing tumor? Or is it a rapidly advancing, potentially life-threatening malignancy? This single, striking physical sign is the starting point for our investigation today. We've got to meticulously differentiate between several conditions because, well, the patient's vision, and sometimes their life, depends on it. Okay, let's dive right into this. Here is our lineup of suspects. Thyroid eye disease, idiopathic orbital inflammatory disease, rhino-orbital mucormycosis, cavernous hemangioma, and finally, rhabdomyosarcoma. Let's start with suspect number 1, thyroid eye disease. This is our usual suspect. In the world of adult proptosis, thyroid eye disease, or TED, is absolutely our baseline condition. It's something we always have to consider first because it's actually the most common cause of both bilateral and unilateral proptosis in adults. At its core, it's an autoimmune disorder, frequently tied to Graves' disease. But here's a massive clinical pearl for you. The major clinical risk factor for developing TED, once a patient already has Graves' disease, is smoking, and it's dose-dependent. The more cigarettes smoked per day, the higher the risk. Clinically, you're on the lookout for lid retraction. Our source material points out the Dalrymple sign, which is a moderate, bilateral, asymmetrical lid retraction, and the Cocker sign, which is the severe version. You're also going to see restrictive myopathy. This is where the eye muscles actually undergo fibrosis, which restricts movement, and it most commonly hits the inferior rectus muscle. Oh, and you have to beware of the hidden danger here. Optic neuropathy. Those enlarged, congested rectus muscles, they can compress the optic nerve right at the orbital apex, causing severe visual impairment, even if the proptosis itself doesn't look all that bad. Moving right along to suspect number 2, idiopathic orbital inflammatory disease. I like to call this one the mimicker.
So the crucial point here is how we contrast idiopathic orbital inflammatory disease, IOID for short, directly with TED. While TED is usually a slow burn, kind of gradual and typically painless in its fibrotic stage, IOID just bursts onto the scene. Our source explicitly notes that IOID typically presents with acute or subacute ocular and periocular redness, swelling, and, importantly, pain. Now, IOID is a non-neoplastic, non-infective, space-occupying inflammatory infiltration, but the single most important thing to remember about IOID, it's a diagnosis of exclusion. Because it masquerades as so many other things, like infections or even malignancies. You've got to carefully rule out systemic inflammatory conditions and neoplasia. In fact, you sometimes even need to do a biopsy just to confirm it.
Next up is suspect number 3, rhino-orbital mucormycosis. This is the deadly invader. Okay, we're shifting gears here from chronic and subacute stuff to an absolute ticking clock medical emergency. If you take nothing else away regarding this condition, remember these critical risk factors. This deadly invader extremely rarely affects anyone who is immunocompetent. It specifically targets patients in diabetic ketoacidosis, DKA, and those who are severely immunosuppressed. The infection happens when they inhale spores, which triggers an upper respiratory infection that just ruthlessly spreads to the contiguous sinuses and then right into the orbit and brain. So anticipating this super aggressive fungus means you've got to spot those underlying systemic metabolic red flags the second that patient walks through the door. And this quote right here brilliantly illustrates the horrifying reality of this disease. The fungal hyphae literally invade the patient's blood vessels, which results in an occlusive vasculitis. Basically, it cuts off the blood supply, causing the orbital tissues to infarct and die. And that dead tissue, when combined with septic necrosis, creates this classic, deeply memorable clinical pearl, the black eschar. If you see this black, necrotic tissue on the palate, the nasal septum, or the eyelids of a diabetic or immunosuppressed patient who has facial swelling, there is no time to wait. You are dealing with a life or death emergency that requires immediate intravenous antifungals and surgical excision. All right, suspect number 4. Cavernous hemangioma, the adult space invader. Let's lower the tension just a bit and look at our first tumor. Cavernous hemangioma is actually the most common orbital tumor in adults, and you'll typically see it presenting in middle-aged women. It behaves like a low-flow vascular malformation. If you look at the imaging and the gross specimen, notice how beautifully well-circumscribed and perfectly encapsulated this tumor is. Because it's bound within this capsule and separated by fibrous septa, it grows super slowly. This leads to a gradual, painless, and progressive unilateral proptosis. And thankfully, because of that nice, neat encapsulation, it's relatively easy to just pop out surgically if it starts causing symptoms.
Which brings us to our final suspect, number 5, rhabdomyosarcoma, the childhood space invader.
But, tumors aren't just an adult problem. Rhabdomyosarcoma comes from undifferentiated mesenchymal cells that can differentiate into striated muscle, and it's the most common primary orbital malignancy in children. The average age of onset, just 7 years old. Unlike that slow, well-encapsulated adult tumor we literally just looked at, look at the scan for this one. You can clearly see this poorly defined mass of homogeneous density, and it's causing terrifying adjacent bony destruction, sometimes even spreading intracranially. The proptosis is unilateral here too, but it is rapidly progressive.
Now, what's really fascinating about this slide is how it brings our whole investigation full circle. Our source material provides this incredibly vital textbook tip. Rhabdomyosarcoma can actually mimic an orbital infection. A kid might come in with rapidly progressive swelling and redness of the overlying skin, looking exactly like the orbital cellulitis or the inflammatory mimickers we discussed earlier. But here is your detective's clue. While it looks totally inflamed, the skin is usually not warm to the touch. Missing this subtle distinction and treating for a simple infection while a sarcoma is rapidly destroying the orbit is a trap we absolutely must avoid.
So let's pull all these clues together into our ultimate diagnostic cheat sheet. If your patient is an adult with gradual painless proptosis and lid retraction, especially if they have a smoking history, you've got to think TED. If it's an adult with acute, painful swelling, you must rule out absolutely everything else before diagnosing the great mimicker, IOID. If your patient is immunocompromised or in DKA, and they've got facial swelling and a black eschar, sound the alarm from mucormycosis. For a middle-aged adult with slow, painless proptosis and a perfectly encapsulated mass on their scan, that's likely your cavernous hemangioma. And finally, if a 7-year-old child presents with rapid, infection-like swelling, but you see aggressive bone destruction on the imaging, you have to suspect rhabdomyosarcoma.
As we close out this case file, I want to leave you with this one provocative thought. When a patient sits in your chair with a bulging eye, the clock starts ticking. The difference between a slow-growing benign mass and a rapidly fatal fungal invasion really comes down to your ability to spot the subtle clues. Is it a smoking history, a hidden metabolic crisis, or maybe a cold, non-tender red swelling? If you master these distinctions and trust the structured evidence we've mapped out today, you won't just be making a diagnosis, you might actually save their vision or even their life. Thank you so much for joining me for this explainer, and hey, keep those detective skills sharp.